Thank you. Good afternoon, everybody. Welcome to this meeting of the Healthcare and Wellbeing Scrutiny Committee being held on Monday, the 27th of October, 2025. For those present in the meeting room, if the fire alarm sounds, please leave the building by the nearest exit and make your way to the fire assembly point in the car park. The agenda papers and other relevant information for this meeting are available for public viewing on the Herefordshire Council website. The Council is streaming this meeting live on the Herefordshire Council YouTube channel and is making a recording. Others are permitted to film, photograph and record public meetings, providing it does not disrupt the business of the meeting. At present, there are no members of public in the building or in this meeting. Microphone usage. For participants in the room, please raise your hand to indicate that you'd wish to contribute. When invited to speak, press the button on the right-hand side of the microphone unit and speak directly towards the microphone. Please remember to turn your microphone off once you have finished speaking. Please ensure that mobile phones, laptops and other devices are turned to silent. For participants in attendance remotely, and I think we have 3. If you'd like to speak at any point, please raise your hand within the system. If you want to contribute, we will then invite you to name yourself and say what you want to say. Please note that only committee members present in the room may vote. I don't think we've got any committee members online, so that's fine. And welcome everybody dialing in. So item 1 on the agenda today is apologies for absence, and we have received one apology for absence, and that's Councillor Mark Dykes, and I do believe that we do not have a named substitute for Councillor Dykes. So that was item 2. Item 3 is declarations of interest. So can I ask any members if they wish to declare any interest in the agenda item? No. Item 4 is last meeting's minutes. The minutes document of the meeting held on the 28th of July is included in the agenda pack, and that's pages 11 to 14. And no matters of accuracy have been notified to the monitoring officer. I'm content that I sign the minutes as an accurate record.
Aye.
Thank you. Item 5 is questions from members of the public, and this committee has not received any questions on this occasion. Likewise, item 6 is for questions from members of the council, and we have not received any questions on this occasion either. So we can move on quite swiftly actually to item 7 on the agenda, and this is a really welcome to our new Managing Director of Wye Valley Trust, Sarah Shingler, and we welcome you because you're going to chat to us or tell us what exactly the Wye Valley Trust Winter Plan 25-26 is. Obviously, we are all elected members, and I'm sure we all receive comments and questions and probably grumbles about NHS services. It's a very difficult area to manage, but Sarah's going to lead us through a slide deck to explain what the plans are. Sarah, over to you.
Thank you. And really thank you for the invite. I will just caveat that I am just 3 weeks in post today. So I do have Sarah Asinder, who is online. So Sarah is our Associate Director of Integrated Care. So Sarah's going to talk through the POWIS winter plans when we get there. Okay, so first slide. So need to start obviously with the NHS England expectations of trusts and integrated care boards for how we need to manage winter. this year. As we know, winter comes every year. It's not a surprise. So we were looking at the learning from 24-25. Now, as members will know, we sit as part of a foundation group. So not only have we looked at kind of system learning, but we've also looked at learning from across the foundation group, so over in Coventry and Warwickshire. There's a real drive around mitigating that wider system change and how we manage risk, looking at the front door of A&E, but also our elective care pathways and our outpatient pathways. And very much this year around leadership capacity. So we have appointed a designated winter director. There's a winter director in every NHS trust across the country, and also one within the each integrated care board. And much more focus on board assurance and whether trusts are actually meeting what they have laid out in their winter plans. And moving forwards, there's a lot more oversight from the regional NHS England teams. Next slide. So the integrated care system priorities, and these are what you would expect to see. So delivery of the 30 minutes category 2 mean performance. So that's, and that's for those patients who are waiting in the community for an ambulance, that they shouldn't be waiting any longer than 30 minutes. Delivery of the 45-minute maximum ambulance offload. So this is our ambulances as they pull up to the ED department, that the patient is taken off the back of the ambulance and put into a cubicle within 45 minutes. Delivery of the 78% emergency access standard. So this is your 4-hour target. And this year also including children within that. Patients waiting over 12 hours for admission or discharge, that we need to reduce down to under 10%, and reducing the numbers of patients awaiting 24 hours or over for a mental health admission, and to reduce our discharge delays and the eradication of corridor care, which is extremely challenging at the moment given the demand that's coming through the door. Next slide. So this is our winter plan. I'm not going to go through that in detail. I know that you've had the slides, that this is a waterfall diagram about how we are going to achieve that 78% plan. Now, this was the plan that we submitted, that the Trust submitted a number of months ago as to what we were going to achieve through winter. The Trust is off plan for this, and we have recently submitted updated trajectories for the next 2 months into NHS England, and we are just waiting to see whether those will be accepted. The bottom line is, though, is that we do need to hit 78% performance by the end of December. It's more what we achieve throughout October and November is where the revised trajectories are. Next slide. And this is our handover plan. So this is the 20, we should be looking at a 20-minute handover in order to achieve an overall compliance of 45% of handover compliance. We are currently at about an hour, although we are improving now on that position, and there's a whole load of work ongoing, which I'll come on to. Next slide. Okay, so our plans. So our areas of focus within the Trust. We have a improvement work stream called Valuing Patients' Time in place. This has been developed by both our clinical and operational leads, and we have also been working with the National Urgent Care GIRFT team, and the GIRFT is getting it right first time. And this is very much around looking at our processes within A&E, how patients are prioritised, and then how patients move throughout the department. The areas of the programme include maximising our neighbourhood health programme, and hopefully members will be aware that we were successful as a system in our national bid to become an early implementer for the National Neighbourhood Health Programme. We had the first regional meeting on that on Thursday, which was very much well attended, and I have to say that we are already implementing a lot of what is being suggested. We now need to strengthen and embed with more partnership working with our local communities. We need to make sure that our emergency department is not congested. We know that if you haven't got space to see patients or to move patients through the department, then your waiting times will go up, as will the risk in the department. We are increasing capacity and improving flow through our same-day emergency care centres. So these are centres where patients who do need to be seen by an acute clinician on the day and may need some diagnostics, who the aim is that they will receive the diagnostics, receive their diagnosis and treatment, and then be discharged within 24 hours. We are improving our inpatient flow throughout the department. This is called internal professional standards, and this is very much around how our medics and specialties work together. So, for instance, if a patient has been referred to surgery for a surgical review, then there are standards in place as to how soon that surgeon should come down to the department and review that patient, which all adds, one, to the patient experience and safety, and secondly, flow around that 4-hour target of that patient being seen, diagnosed, treated and discharged. And discharge pathway delays remain a challenge, and Sarah will touch on some of our POWIS delays. And there's information which we've recently shared with NHS England national team on the challenges that we are currently facing through POWIS pathways and how that's impacting on our EAS performance. Members may be aware that Wye Valley Trust did go into Tier 1 reporting for urgent and emergency care in Q3 and Q4, and this was because the team were off target for their submitted plan. So that was a 78% plan that they weren't achieving the plan at that time. We are now, as I say, making improvements. So we are receiving support from the National Emergency Intensive Support Team, ESIST, and under some key areas of focus, which are frailty, looking at admission avoidance of our frail and end-of-life patients, and also looking at processes throughout our ED. Next slide. So this is really just around an intro and context about the work that the teams undertook in the trust and in the system to actually develop that winter plan. So I'm not going to say any more than that because I'm aware you have got the slides. So next slide, please. So these are our schemes. So I'm not going to go through them in great detail. Apart from sort of to pull out some of the key areas, so care closer to home. We all know that if we can support patients to remain in their own home when they have an acute episode, then the outcomes for the patient and the system are much better. So we are at the moment working with 111 to make sure that those dispositions where a patient is told to come into the emergency department is that actually those patients are triaged through our single point of access, where our clinicians can actually make an assessment as to whether that patient will be better served by their local GP or by other services in the community or in one of our same-day emergency care centres, so that they avoid the emergency department, and they also get the right care at the right time by the right person first time. Call before convey, this continues to be a challenge. So this is working with our ambulance service. If they have got a patient at home who they consider may be able to use an alternative pathway, to contact the single point of access so that we can assess, advise, and hopefully refer that patient somewhere else apart from the emergency department and trust admission. We're currently sitting at around 16% of call before convey, and this remains a challenge nationally, and we are working with the ambulance service to increase the numbers within that area. And we are just doing a test of change with one of our frailty consultants working within the single point of access to review calls as they come in, to see whether we can do more in order to keep our more frailer end-of-life patients at home, with that geriatrician actually overseeing the care of these patients, with a view to avoiding between 4 and 5 admissions a day. We're waiting for the readout, but at the moment that's going extremely well. So what we will want to do is to see how can we streamline this and put this in place sort of for the end of November, so that we do go into winter with that additional support in the community. The acute floor I've talked about, this is very much around acute processes. It's about how our clinicians work together across medicine, surgery, orthopaedics, oncology, and we're also reviewing our criteria to admit, because at the moment our same day admissions which go through the emergency department, we are seeing an increase. So there's work ongoing where, we make sure that senior decision makers are reviewing patients before that final decision is made to admit them into hospital, and whether we can use other pathways that are available to us. Next slide. There's lots of work around our inpatient wards, around how we're working within our acute medical unit, the internal professional standards I've touched on, and we also have an acute surgical unit in place now, which works very closely with our surgical same-day emergency centre. And we are looking to increase the throughput and the activity that goes through these areas. We have reviewed our escalation plans, particularly in relation to how we work with PAWIS, but also how we escalate within and across our own system. So how we work with primary care, how we work with the voluntary sector, at a point where we are beginning to get overwhelmed within our emergency department and inpatient wards. And we also have a number of ways that we can discharge patients, such as the discharge to assess model, the hospital at home model, the bridging team when pathway 1 capacity becomes challenged and we're having delays in the hospital. So there's a number of different ways that we can discharge and access support. Next slide. The increasing the risk threshold. So I've just touched on that we are seeing more emergency admissions coming through the front door at the moment. And there is something around training and supporting our clinicians that on what is available and what the competencies and the skills are out in the community. We are an integrated trust. We do have community hospitals, so it is about how do we raise the acuity and the type of patients that can go through our community hospitals. But to do that, it is a different way of working. So we've currently got a programme of work ongoing now at the moment around how do we appreciate and understand what further is needed in order to be able to step more patients down into our community hospitals when they are fit to do so. And then we have a number of sort of system and trust-wide schemes ongoing around discharging patients sooner, looking at getting patients to the discharge lounge and discharge before 12 midday, because that means that our beds are available much sooner than where we currently are at the moment. And next slide, I think we're on to Powys, I think. Oh no, so this is really the work we are doing around the discharge to assess. I'm sure members are aware of the real innovative work that's taken place in Herefordshire around the BCF and the delegation of that into One Herefordshire. We are currently just doing an end-to-end review of that discharge to assess pathway. One, to look at the effectiveness and the outcomes for our local population, but also from a cost perspective. So there will be further changes over the next few months on how we deliver discharge to assess. Next slide. Clinical support, absolutely crucial for us to maintain and improve our standards, certainly around cancer and our 4-hour standard through ED. So we recently opened on the 29th of September our community diagnostic treatment centre, and there is some information there on what our targets are of what activity needs to go through that centre over the next few months. I'm not sure how many of you have been, but it's a wonderful centre, and we're now just finalising the arrangements of how primary care will directly refer into the centre in order to be able to order diagnostics for their patients, to save them coming into either the same day emergency care centres or into A&E, because we all know that that does happen for patients who've got ongoing chronic conditions. Next slide. And I'll hand over to Sarah for Powys.
Many thanks, Sarah. Hello, everybody. So the next few slides are just really about Powys's plans. So as you probably are aware, about 20% of our admission demand comes from our Powys patients. You know, we are their nearest DGH. Much of our demand is about 20%. However, Powys patients make up 50% of our discharge delays. So we have for a number of years been working with Powys to see what we can do to support them and to take their patients back sooner, or at least when they're medically optimised for discharge. We do an awful lot of work in Herefordshire, don't we? And we have done for years. Local authority and the NHS Trust have had that in place for a long time. So we now turn our attention to Powys. So Powys have just provided us with a few slides in terms of what their plans are, in terms of not only trying to reduce the admissions coming into hospital that might not necessarily need to be there, but also how they can reduce those discharge delays. So these are a number of things that Powys County Council particularly are working on. They're looking at paying retainers for their dom care agency and enhancing their brokerage capacity so that we can try and access those packages of care sooner, so that our patients don't experience delays when they're clinically optimised for discharge. They're also looking at expanding the team in hospital. So unfortunately, Powys don't provide a discharge to assess pathway. They assess their patients in hospital, and it's a different way of working. And so we're keen for that assessment capacity to be increased. So again, just to reduce patients being in hospital when they don't need to be. And they're also looking at a trusted assessor model. So we're waiting to hear how that might run. Next slide, please. So these are a number of schemes that Powys are working on, and we're working with them in a sense of we're quite good at this stuff, aren't we? You know, we've been working together for a long time, and we've got some fairly decent models, particularly around admission avoidance over the last few years. And looking not just to support with advice and guidance in terms of lessons learned from Herefordshire, but also how can we work together? How can we partner up? Do you need some consultant support? Do you need to access some of our services in terms of working alongside each other? So we have had an established virtual ward for a number of years now, and Powys are now working on trying to establish their virtual ward. It will look slightly different to ours. They haven't got the secondary care consultants that we've got that are able to provide that medical oversight. But it looks like they're starting to develop those virtual wards, which will likely be primary care led. They've got a number of other functions that they're pulling together, including a couple of new services around fracture liaison, and also doing much more in the frailty space, in the way of clinics that might see a reduced demand coming through to Herefordshire. And they're also doing a bit around their step-up admissions. So there are a number of community hospitals in Powys. They have, I think at the last count, maybe 8 or 9. They're very spread out because we know that Powys is a huge county. But we're working with them to see if we can give Powys patients the same opportunities that a Herefordshire patient might get. So if a Herefordshire patient goes to our frailty SDEC unit, the likelihood of them being turned around and discharged the same day, having some diagnostics, as Sarah's just described, it is possible. If a patient comes to our frailty SDEC and they're a Powys patients, they won't be able to go home that same day. There aren't the services set up for them to be able to do that. So we've managed to get an agreement from them to test that with our geriatricians in November, to see if we can see a patient in frailty SDEC in Herefordshire and actually get them home the same day. So there's some quite exciting bits to come, I think, in terms of what we might be able to do for our Powys patients, so that they don't have to stay even just overnight in a Herefordshire bed, and we can get them home where they belong. Next slide, please. Again, trying to do a little bit more in terms of admission avoidance and what we can do from a same day perspective. They're set up differently, it's just working out, what might they be able to do to support this. So they're trying to develop a single point of access. And again, we're going to test that in November. How does it work? What have you got access to? They're not as well established as us. I mean, we're fortunate, and we've got advanced clinical practitioners that work in our single point of access. Powys have got links, they've got district nurses, they've got a GP. So it's what can we do together to see if we can get your patients home when they should be home, or not admitted in the first place. So there are a number of things that Powys are planning. They have already got a full response service, and it's provided by their St John's ambulance. But again, it's about how they link in better with their community teams. So we're really interested in what they're doing, and we'll keep a close eye on it. Next slide, please. And then in terms of their discharge pathways, so as I said at the start, 50% of our total delays from Herefordshire are Powys patients for 20% of our demand. And they are split between the health and adult social care delays, so they're not working as an integrated provider at that point. There are a number of things that they have done. They've repurposed some of their beds, and I must get this acronym right. It's ready to go home units. So sort of similar function to a D2A bed, if you like, trying to move patients into a space where they can receive that proper assessment, an element of reablement, and almost like a stay to be able to then get them home to that next step. And also IVO-PAT, so that's where we give intravenous antibiotics in the home. Herefordshire have got a really well-established service. It's been running for about 12 years, but Powys haven't got that. So that they're working through a plan for us to be able to discharge patients home on an IVO-PAT pathway. And it may be that secondary care in Herefordshire provide the medical oversight, but actually that the community nurses in Powys are able to go and deliver those antibiotics, because we know it's better for patients if they're not sat in hospital just waiting for an injection of antibiotics when they could be sat in their own front rooms. So we're really, really keen to see if we can get that one off the ground. And then there were a number of other things in terms of what they're doing digitally. So Powys are trying to work on their digital programs a bit more, to try and increase that flow, to try and smooth things out and make their processes smoother. So we're really interested to see what the results of those are. And I think that might be the end of the Powys update. Yes, thank you.
Thanks, Sarah. So, and this is our workforce, our planning slide, which, as we know, our staff are so very, very important. And it very much around the vaccination and the support, the emotional support and the psychological support that goes into our teams through winter. The moral injury, that we are causing to staff with caring for patients not in designated bed spaces. We can't underestimate that. So there is access to mental health support, and we do have designated rest and recovery spaces. And we do make sure that there is provision of hot meals and hydration stations across the Trust and across our community hospitals. We are doing well with our staff vaccination at the moment. We are at 23%. So we are edging towards the 5% improvement on last year that NHS England set each trust. Next slide. So the risks. So there are absolutely risks within the plan. We are going to continue to use temporary escalation spaces to maintain flow and reduce that congestion within the emergency department. We do flex those spaces if we don't have them open 24 hours a day, 7 days a week, if the discharges and the Powys delays are within acceptable levels, then we will close those escalation areas down. However, it's expected that they'll probably be more or less fully utilised throughout the real depth of winter through December and January. We are having acute floor estates work taking place in October through to February, and this is to increase our same-day emergency care and our ambulatory capacity. So this is so that we divert patients from the ED, they don't even get into the emergency department, and come into those same-day emergency care centres. It's unfortunate that we are doing this work now, but this is part of capital bids that came through quite late in the year, which we've had to turn around quickly, and we need to have completed those works by March 26. Otherwise, we lose that capital spend, and we obviously don't want to do that. But we will be moving services into other areas to really minimise the impact on the A&E capacity. We are maintaining high levels of elective activity, and we will ring fence elective capacity as well. However, as members I'm sure are aware, that if the emergency department and flow throughout the hospital gets to a critical level, then unfortunately we do have to make decisions based on safety as to whether we do cancel some elective activity, but there's certainly no plans to do that as we move forwards. Sarah's just touched on the Powys and the UEC admission avoidance schemes, which we are offering full support. And then there is the competing priorities around elective versus non-elective. So the activity that comes through the door on a daily basis, we can't close A&E. It's 24/7 direct access service. But there's also the delivery of the financial plan, whilst also ensuring that patient safety. So our staffing models are regular reviewed 2 or 3 times a day, depending on the demand at the front door. And in the face of this as well, we are delivering a £25 million cost improvement programme. Currently in the Trust, we're doing well. We've delivered 10 million of that plan, and there are plans in place to continue to deliver to plan for the end of March. And that is obviously on receipt of successful transformation schemes. So I think that is it. I think, yes.
Wow. You've got huge plans, and, I don't want to be too cynical, but I just worry about, capacity and how you're going to achieve all this. I will come to Hilary at some point this afternoon just to talk about discharge to assess, because I know, Sarah, that you work really closely with One Herefordshire Partnership and the ICB, and obviously the local authority, which is Hilary and Councillor Gandy's priority. So, we'll come to Hilary and Councillor Gandy if we can in a minute. I was reading the other day that Herefordshire has really quite specific issues with capacity and planning, but I think you've come from the acute Worcestershire Hospital, so they must be in a similar situation to us. So I'm just hoping that you've been working on plans over in Worcester that you're going to bring to Herefordshire, so that we can get your improvements going quite quickly, because I think they're very similar to us with CQC requiring improvement, and we all know, as we've had Y Valley here to explain the CQC report from 2024. But it's good that you've had that experience in your previous role, and also that you were a clinician. And I think that's really important for somebody working in the health industry or any clinical role. Committee members may say the opposite, but to me, I think it's really important. And I know Councillor Gandhi probably has the same idea, because she's also worked in the environment, shall we say. Going back quite a few slides, you did mention the National Neighbourhood Health Pioneer Programme or project or plan. And this is this pilot's plan that you've been lucky enough to be included in. Although, it's big, isn't it? 43 areas, and you've had your first meeting last week. So it would be interesting at some point that we know how you're getting on with that relationship. And part of the 10-year planning for change, that would be an interesting topic as well. And Wave 1, I believe, was a £10 million investment from government. So I just wondered, is that set up equally between the 43 areas, or is it given out on numbers? So that would be an interesting one to know, so that we know how much more money Y Valley have got to try and support some of these neighbourhood providers. The other thing that I was going to ask Sarah Attinder, and Sarah, have you changed your name, because your face looks familiar? Yes, I thought you had. Sorry, you're only tiny on the screen, and I thought, I'm sure I know this lady from working at Y Valley for so long. Bless you. And you're sticking at it, so good for you. The other thing I will say is a thank you for the glossary of terms. I think one of our officers had already sort of jumped on that one for us, because we at this committee and Herefordshire Council don't like the use of acronyms, especially when you're in meetings where the public are listening in or whatever. So we really are grateful for that, although my goodness, there are a lot there, aren't there? Yeah. And it's like some of them I think, oh, you've just made that one up. That looks a really long word to explain something that's quite simple. Okay, so I'll leave it there for a second. If you'd like to answer what I've just said, and then we'll go to Councillor Gandhi for any comments.
I'll do my best. So Worcester. So I was over in Worcester for 2.5 years. So I was a chief nursing officer over there, but I have a background as a chief operating officer and directors of transformation in other systems. I was the senior responsible officer across Worcestershire for UEC, recovery and transformation. So I have to say Herefordshire is in a very, very different place to Worcestershire in the relationships that are absolutely in place across partners. And it's a real privilege to actually come into a system where you can straight away begin to work together. When I went into Worcestershire, that was very different. And the Acute Trust obviously being an integrated, health and secondary care provider makes a big difference. But the real longevity of relationships with the local authority and with primary care make this really fertile ground in order to build. So that my experience of kind of new models of care, very much looking at admission avoidance and also how we work differently with our community hospitals and really capitalise on the massive opportunities that they are, is kind of what I bring. And already working closely with Sarah and some of our consultant colleagues to think about what do we do differently. So those conversations are already taking place. The National Neighbourhood Improvement Programme. Thursday was great. There are so many systems who are trying different things, and they're not really difficult things. You know, they're actually quite straightforward. But as I say, because of where we are and how we work together, I don't think it will be difficult for us to very quickly come up with the Herefordshire model of neighbourhood health. And we certainly want to do that over the sort of next 4 to 6 weeks. And what this means is that we need to now start looking at the One Herefordshire programme and review and reset, especially as we move towards the national agenda. And in Herefordshire, what we're looking at is whether we could be a integrated health organisation across the system, and that we look at how do we do that in shadow form. And we obviously do that with close working with the ICB Council and primary care. So very happy to come back and update once we're in that position. And the 10 million investment, nothing has come down the line on that yet. Although hopefully what we'd really like to look at is neighbourhood health centres. So where we really, change the way that we are communicating and allowing the public to access health and social care and voluntary sector providers. So if there was money coming down, then we would really like to look at creating something like that in Herefordshire, and maybe more than one, but we just don't know until we obviously see what the plans are coming down the line.
Yeah, I think that's music to our ears, because in the past this committee have questioned about, neighbourhood support, etc. And more importantly, the minor injury units. Yeah. That's the elephant in the room, and I'm sure Councillor Tillett's going to expand on that one in a minute, because it is something this council has got concerns about, because we've tried to understand the reasoning for closing them and keeping them closed, and not looking at the bigger picture, which it looks like you are now. Just before I hand over to Councillor Gandy, just looking at some of your statistics, I was like, oh my goodness. And the one in particular, it was about the ambulance handover times. And, that's terrible, isn't it? If we can't get people into the unit, are we delaying their healing or their treatment? We are, yes. And I know somebody who was admitted in January this year actually, and their wait in the ambulance was for 5 hours outside. They were the 11th ambulance in the queue, and it was at that point the hospital stopped admissions because it was completely overwhelmed. So it's good that you're looking at those ambulance times, and it's the ambulance service perhaps we need to get here to see how they're going to improve things through this winter plan. And the other thing, and it's completely gone out of my head now, so I'll stop at that point. I will speak to Councillor Gandy. Would you like to say anything? Sarah, if you turn.
Yes. I think it's important to recognise that the neighbourhood health plan is a joint effort between the NHS and the local authority, and obviously the voluntary sector as well will play a part. And I've received an update from Zoe on her take on the first meeting, and I think there is a little bit of confusion around about contracts and things like that it needs to be ironed out. This is not a simple thing to do, and obviously.
Could you just remind everybody who Zoe is?
Oh, so sorry. Zoe is the Director of Public Health, and I think it's obviously some of us would say yes, it is about buildings, but it's also more than that, because a lot of our people do not have access to buildings because they do not have public transport. In fact, a significant proportion, and we need to be able to deal with that. I think the plan is is a good plan, but I think it's very optimistic. And I suppose many of us have seen plans like this in the past, and they don't necessarily come out in the way that we would hope they would do. I was able to visit the new diagnostic centre behind B&Q last Friday, and it's an amazing building. There's no doubt about it. And once it's up to full capacity, it will take a huge amount of weight off of Hereford Hospital. And the people that I talked to there were patients, that is, were really impressed with the facility. We just need to get our Herefordshire Highways Department to actually put a road sign up that shows where the actual place is. With regards to discharge to assess, I think from my point of view, when we're looking at, and Hilary might want to elaborate on this, when we're looking at this, it seems to work really well in our community hospitals. It doesn't necessarily work quite so well within our Hereford Hospital, where our social workers don't seem to have as much input into the decision-making process. And I think there is a concern that perhaps we are possibly not working as well together, but Hilary might well want to talk more about that. Okay, thank you.
Thank you, Councillor Gandy. I've just remembered what the other thing was, and it was about corridor admissions. And that person who had to wait goodness knows how many hours to get into the hospital to get diagnosed with a fractured pelvis, then had to stay in a corridor overnight on a trolley. You know, not an old person, but you know, still very uncomfortable and quite a derogatory way to look after somebody. So it's good. It'll be interesting to see how you're going to come up with more beds or more space or a bit more privacy, shall we say. And as you said, Councillor Gandy, the plan is good if it works. So that will be a later plan for us to have a look at the actual results. So Hilary, would you like to say anything regarding discharge to assess? And I know Sarah Asinda is, you know, up on the ball with all of that side of things as well, because she's very involved, or was.
Thank you, Chair. I think certainly from an adult social care point of view, as ever, we are there to support and we'll work closely with the hospital through the winter. We always know that's a particularly pressured time, and we'll do what we can to support the rollout of the plan. I think in terms of discharge to assess, we are, you know, collectively as a system, we are looking at it, and I'm sure Sarah, Cinder, too many Sarahs, would support with that. So we're looking at literally from start to finish of the whole pathway of discharge to assess, to ensure that we have the most efficient system and the most effective, and that we're making most use of all of the facilities and the systems that we've got. We've had the same discharge to assess process for quite some time, and therefore it makes sense for us to review that and keep it under review and ensure that we've got something that's fit for the future. I think, you know, we need to look at that in the bigger picture. So what are the outcomes? What are the outcomes from discharge to assess? It shouldn't just be another assessment, but actually where do people then move to as part of that? And that's part of looking at those wider outcomes as well. So it's a big piece of work we're engaged with. It needs to be done. And that will be about how we best deploy our resources, as well as how we best use the systems and the capacity at our disposal. Sarah, I don't know if you wanted to add anything.
Thanks, Hilary. No, I mean, absolutely. We're very much looking forward, I think, to reviewing the model and making some decisions about the future, aren't we? I think I'd probably just like to respond to the comment around social care teams being involved at the acute site. Where we are is as soon as a patient doesn't need acute care, and they haven't got their discharge to assess plan nailed yet, we move our patients to the community hospital because they no longer need our acute care. So our social care leads who work with us within our teams deploy their social care staff out to community hospitals because that's where they're needed. So I just wanted to make sure that was super clear. There are very few patients on the acute site that need that next bit, if you like. So they are generally out in our community hospitals, which all ties in, doesn't it, to that review that Sarah mentioned around what are our community hospitals there for. So yeah, I just wanted to make sure I was sort of clarifying that point really. But yeah, looking forward to a full review of the discharge to assess model together.
Thanks, Sarah. And Hilary, do you think we've got capacity in our social worker staffing to make sure this works really swiftly? Because, you know, I'm sure all of us know people who've gone into a community hospital and then they're stuck. And it's all because they're waiting for X, Y, or Z. And it's usually either a package to go home or a plan that they need to have put in place for them. So, you know, you've got past the acute phase, which is great because we're freeing up the hospital, but we're then, I hate the word bed blocking because it's a sad state, isn't it? But, you know, we need to be able to jump on those people who need support in another way so that we can enable them to go home. And I know we're looking at technology, etc. And I think there is an awful lot more that we can sort of follow up with. Any comment, Hilary? I'm sorry to torture you when you're not feeling very well, but your input is most welcome.
No, that's fine. Excuse me. We haven't got unlimited capacity, so and we do work really hard to ensure that we don't keep people in hospital any longer than they need to be. Everyone knows that's not to anybody's advantage, and we do work really hard, but inevitably there will be some delays, and we'd never like to see that. I think what we need to, where we are looking, is to ensure that when we move people out of hospital into whatever package of care is required, that it's actually the best fit. So what I don't want to do is keep moving people into different provisions just because we need to keep that flow going. So it is about, so this whole piece of work that Sarah and I are engaged with is how do we make best possible use so people get to the right place. I hate talking about places and people, it doesn't feel right, but they get to the place where is best to meet their needs. We do need to do more in that space of technology. And our technology enabled care manager is very engaged with that and is working closely with the hospital team. I can't say that there won't ever be delays. I would be that would be very wrong of me to say that, but we do work extremely hard to minimise those delays as far as we possibly can. And I think the other bit that we're looking at is, and it's about looking at what other authorities are doing. Are there other ways? And there are other ways that we can use the existing resources that we've got in different ways in order to meet needs, which isn't necessarily just about doing what we've always done, but are there other and different ways that we can meet people's needs? But at the end of the day, we do have a market, which is predominantly, you know, we've got a high number of self-funders in the market, so our ability to get care at a cost that's affordable for the council is a challenge every day for our brokers. I'm not saying any of this as a means of saying that we're not doing the work that we need to do, just saying that there are challenges inherent in everything that is around this, but we are absolutely committed to doing it as quickly as we can to ensure that people aren't staying in hospital, be it acute or community hospital, any longer than they need to be.
Yeah, and that's really important as well. You know, we talk about all these people getting stuck in a situation, but I think the important thing that we need to make sure we can try and support them with is if they're self-funders, how they can get the care. But if not, making sure that they've got a package set up for either funded nursing care or continuing healthcare. And we all know that there's, you know, big gaps in those areas. It's a long process to actually work out who pays for what, but you know, we'll try. Thank you, Hilary. Okay, so can I go to committee members for any questions, comments, concerns, or anything else? Councillor Davies.
Thank you, Chair. I'd like to start with the priorities list that was on the second slide. So delivery of 30-minute category 2 mean performance, etc., etc. How is that priority list a benchmark for what's going to be achieved, and how are you going to able to fulfill that requirement? I mean, is it an aspiration or is it a target?
So these are the integrated care system priorities. This isn't just dependent on Wye Valley Trust. So it's Worcestershire Acute, it's WAMAS, the ambulance service. So, but yeah, so the priority and the aspiration that the ICS has set is no more than 30 minutes for a Cat 2. Yeah.
Okay. If I'm okay, Chair, just to carry on that, the discharge pathway delays is inextricably linked to everything that happens from an individual going into an ambulance to go to emergency, to being treated in emergency, to having acute care, to going from acute care onto a ward and discharge, and that temporary escalation space you mentioned. So how does that temporary escalation space, what is it? Is that a corridor? Is that a porter cabin outside in the car park? What kind of facility is that, and how can we integrate it better potentially?
Okay. So there are different. So if we there's different terminology. So there's temporary escalation space, and then there is boarding on additional patients on our wards. Okay. So to kind of take the latter part of your question, so we've been the trust has been boarding additional patients on its wards for a long time. And we have now done some estates reconfiguration so that some of those boarding temporary spaces we've actually made into ward beds now. So they're no longer temporary, they're no longer boarding. Now, we will do that where the estate allows us to, where there's obviously oxygen, suction and everything that we need, and the space from a health and safety perspective to do that. So a patient can be nursed in a corridor on a ward with screens in order to maintain dignity. We also will open other escalation areas which you don't normally bed patients in. For instance, the endoscopy recovery area, which actually from an area point of view, it's private. There are good facilities there. However, it's not an environment which is an inpatient ward, and it then begins to impact on our elective endoscopy activity, and then impacts on obviously our other performance and activity targets. And then the other spaces is in the emergency department is in corridors, because there's just no space within cubicles. And what the clinical teams have to do is to risk assess, 2, 3, 4 times a day against that category 2 performance and patients waiting extraordinary amount of times for an ambulance, versus the safety in the department and whether we board more patients on the ward. So that's a dynamic risk assessment that takes place. There are governance processes in place for patients who should or should not go into a temporary escalation space. There are quality checklists. We've done everything that we can in order to do our best to safeguard the interests of patients who are in a non-designated bed space. But it doesn't take away the fact that they shouldn't be there, and we absolutely know that, and our staff know that. And we are working hard with kind of the admission avoidance and everything else that I've talked about in the presentation. And certainly moving forward next year, we're really hopeful around the neighbourhood health and looking at the prevention and more proactive work, that next winter will be very different to this one, is what we're working towards.
Any other? Oh, right, we've got all of you. So we'll go with Councillor Tully first, then Councillor Thomas, then Councillor Cole, and then Councillor Tillett.
Thank you, and welcome to your new job. I've not been doing this for very long either, so many apologies. I'm aiming to bring some ignorant questions that hopefully shed light on things, maybe, if that's at best. There's a couple of things that were really positive that I heard, and I wanted to share that one of my residents has recently told me how positive being the hospital at home service had been for his wife, and how it just kind of really enabled him to be able to get out and do things as well, and she was really happy. So thank you for that. There was another positive thing. There was something else that there was loads of things that just, it just sounds really, it's unbelievably overwhelming what has to be dealt with, and I think looking at the community hospital seems really positive as well, and the opportunity that's there. I think I'll come back to that, but so I'd question about the ambulance waiting times, just in terms of that report and that slide, and I think that what you were saying was that it's currently not that there's the time that the time that's aimed for is not, you're not there. So I guess my question is, why did the plan have something that didn't feel like it was achievable? Maybe I'm unclear about what is it a target or is it a plan? Because if it's a plan, why has it not been, this is not going to be possible, and here's what is possible. And I'll just ask the other question that's maybe a little bit vaguer. Is that all right? And yeah, I think the positive thing about there's so many grey areas between those targets, right? I think Councillor Davis just explained that, all those grey areas between those targets and how important they all are. And I just wondered your perspective around kind of those areas between the targets. It's really important to get to those targets around eradication of corridor care and those things. But the sorts of things that are going on that enable you to balance all of the competing priorities that you said around delivering the plan that you have, the whole year round plan, yeah, I think I'll stop because there's too much more there. But if I get a chance again, I will. Thank you.
Yeah, you'd be welcome to have another round in a minute. But Sarah, if you'd like to respond.
Yeah, thank you, and thanks for the lovely comments about services. We'll take those back. So the thing nationally, we have the targets that come down the line, okay, and we, regardless of kind of what your delivery is at the point that those targets are published, we have to put forward recovery plans, recovery trajectories of how we then get up to meet that target threshold. So certainly around where Wye Valley is at the moment is they put plans forward around the handover times and the emergency access standard, so the 4-hour standard. I don't want to say ambitiously, but it's very difficult when you are wanting to work hard for your local population to make improvements, and some of the challenges that are outside of your control, such as at the moment the POWIS delays that we are experiencing, as Sarah touched on. 50% of our delays are POWIS, which we don't have direct control, which has driven kind of our lack of progress across improving that emergency access standard, and that's the conversation that we are currently having with the national teams. But because of the work we're doing with the national team, we've put forward revised trajectories, okay, around that EAS standard, which we are actually now meeting. So that it's more realistic for when we are expecting some of our improvement work to reach full fruition. So that is when we're expecting to see that step change. Around 45-minute handover, it's very, very much driven by the overcrowding in the department and the number of delayed discharges, or the correct term around patients with no criteria to reside, are actually in our hospital and in our community hospitals at that time. Because if you can't get flow out of your emergency department, you then have no space in order to bring patients off the back of ambulances. I have to say we are improving. So for instance, at the weekend, our handover performance was at 23 minutes, our average handover for yesterday, and 47 minutes average handover on Saturday. So we are absolutely, where we've got to get to now is consistency and sustainability, and to continue to improve. And unfortunately, a lot of that is driven, as I say, with some things that are outside of our control at the moment around some of the delays that are occurring. So we are, there's a number of the plans, and there are stepped improvements that we expect to see on a monthly basis, and we're absolutely moving in the direction that we need to be now. Is that
I don't want to burst your bubble, but it's great to hear that ambulance handover times have come down, but we're not in winter yet, are we? So, sorry, that's a really negative thing to say. So we'll go back to Councillor Thomas and see if he's got something positive, like Councillor Tully had to say.
Just before that, can I just come back? So our activity levels at the moment are really high. So the demand coming through the door is exceptional. So, and that's, yeah, I know.
When we hear these plans, which sounds a really good plan, I'm old enough to remember going in A&E as a, teenager and being seen almost straight away. In the last, 6 years, I've been into A&E 3 times, twice for myself with broken bones, and the last time with somebody else. It's very obvious, you don't need to have much intelligence to realise that most, well, not say most, but probably 50% of the people in A&E should never be in there in the first place. They have got sniffs, they've got colds, the child's just got something very minor. And once they're seen, they're discharged straight away. So I think we need to put the horse before the cart. And I think we need to sort out, first of all, there's no doubt that the cottage hospitals, or what they were called, community hospitals, they're now renamed, had sort of minor injuries. I've used the one in Ross for myself and for members of my staff, and they were brilliant. If a nurse couldn't deal with it, they brought a doctor, a GP in from Alton House, and it was dealt with within 10 minutes, quarter of an hour, or something like that. Again, you would reduce the flow. So I think you need to go back to sort of basics, because it worked extremely well, and the population of Herefordshire hasn't increased enormously. But what does concern me, having been in and been with people from Powys, do Powys pay us if they send a patient in? And why are we supporting, sorry to say, it sounds very racist, but why are we supporting the Welsh when their health service is sort of in absolute disarray? And I'm half Welsh, so I'm okay, and this chap here is all Welsh. But, why are we sort of taking enormous numbers from Powys? Because they have got hospitals in Powys. Why aren't they using them? You know, so I'm sort of, yeah, the plan works, but as soon as we get a good flu outbreak, which I'm sure we will get this winter, it'll all go out the door as usual. And you know, every time I've been into A&E, there's never been a single ambulance sat there waiting to discharge. They've been in, they brought them in, and so why are we, not just Herefordshire, everywhere? If you watch the ambulance progress on television, it's all the same. So why? Is there any sort of thought and research going into sorting out why so many people are in A&E?
There is. So that's an ongoing piece of work. And what I have agreed, as I say, I'm very, very new into post. I need to look back at the minor injuries issue. And I think I've agreed to bring a briefing back November or December, didn't I? Yeah. So and actually just around the position around those minor injury units. I don't know enough now to comment, I'm afraid, on the MIUs, and I certainly don't want to say something that's not accurate. Around the Powys issue, we are, you know, this has been escalated, the issues that we're having, right up to the national team, the national NHS team, and there are meetings scheduled with members of Welsh Government shortly. So we've done as much as we can do as an organisation, but as I say, at the moment it's out of our direct sphere of control.
And just going on to the other question you asked about, does Wye Valley get charged, or does Wye Valley charge Powys? Yes, you do, don't you?
We get income, yeah, of course. There are lots, you know, there are funding stream issues, and the amount that the English NHS pay for treatment, and it is different to Powys, and again that conversation is taking place.
Did Sarah?
I think it's also important to point out that Powys only has one closes at 4:30 in the afternoon and opens at 8 in the morning, and the other two open at 8 and close at 8. So they're not hospitals in the true sense of a district general hospital.
So you've just added some fuel to a fire, haven't you?
Well, it's just
No,
it's
facts.
the fact of life. I mean,
I know.
My ward is on the border of Powys, so I have residents who go to GPs in Powys, in Prestine, but they have come to Hereford for hospital treatment, and that's because there is no district general hospital in Powys. So
It's just a regional thing. I wondered if Sarah wanted to come in, and she got her hand up. So come on back in, Sarah.
Thank you. Yeah, just to go back to Councillor Thomas, I think it was a question about demand, you know, why people coming to ED and they weren't there years ago. I mean, we're constantly looking at the patients that attend ED. It's a constant review, audit, etc. Surprisingly, the majority of people brought in by ambulance absolutely should be brought in by ambulance. So there is a thought of, you know, these patients don't necessarily need to be there, but the majority of them that are brought in now do. And because we utilise our call before convey, as Sarah referred to earlier. But what I would say is we're just about this week actually to commence a pathway where currently if a patient rings 111, they quite often get sent to ED. You know, the outcome is attend ED. And we're very clear that those patients that are diverted from 111 to our ED, some of those don't need to be in ED. So what we're doing this week, and it was included on the slides, is we're testing a pathway whereby 111 divert that patient through to the single point of access in the community. And then the clinicians in the single point of access are able to say, actually, this patient would benefit from, whether that's a GP appointment, potentially a visit from a therapist, you know, might need some social care support. So I just wanted to advise that we're always trying different schemes to try and reduce the demand into our emergency department, and this is the kind of latest one which we're hoping might be successful, and we can grow to try and keep people away from ED when they don't need to be there.
Yeah, that's a really good answer. And I think that was one of the things I was thinking about how is the trust working with NHS 111 and urgent treatment centres to manage demand. So I think that collaborative working is definitely the way to go. And we've also got Taurus in the out of hours service. And I'm not sure how much capacity they have that they could expand on, but that's for another day.
Just around when you mentioned learning from Worcestershire, so we implemented through our single point of access in Worcestershire the 111, and we divert between 85 and 90% of all referrals do not go into the emergency department, whereas the 111 disposition was the emergency department. So that is really, so I think we're avoiding between 12 and 15 calls a day from going into the emergency department. So if we could even get a third of that, it would make a big difference.
And in this plan, there's no mention of Taurus or the out of hours service. So, but I'm sure you're having conversations with them to see how they can expand their services and support your demand. Councillor Cole, I think you were next on the list. If you use your, yeah, thank you.
Winter maintenance plan goes up till the end of February. Is that right?
Our winter plan?
Yeah.
Yeah.
Now, and what makes you think winter's going to end at the end of February? I can guarantee it won't this year. So doesn't it go any farther? Yeah, we are. 63, you remember.
Yeah, so no, again, it's a dynamic plan. So we would continue. Got obviously the planning guidance was published the back end, well, Friday. So now we've got new targets that we now need to begin working to, which start obviously in March. Yes.
The MRI, entry units. Gentleman from Worcester came down at one of our meetings and said the only thing that was stopping it, or one of the things, the main thing, is practice nurses, is it? They call them. And we got several in our practice down there. Yeah, so I don't think they're very hard to get hold of. And it would be a much better thing to have them. It'll take a lot of stuff off Hereford, as Councillor Thomas said. But why have they got them in Worcester and they don't allow us to have any?
Are you talking about MIUs, Councillor Cole?
Minor injury, yes.
Yeah, sorry.
Yeah, well, minor injury units, they told us that there's these practice nurses they need.
I think initially it came down to our committee that there were staffing issues, but that was many moons ago. And I think that's all being looked at, I think, still. So it's refreshing that in this plan it's mentioned and it's brought it back to the table, basically. Councillor Tillett, are you going to be...
Am I going to be what?
Are you going to be gentle?
That is my default setting, Chair. Actually, I'm going to turn to the Sarah Cinder on screen, if that's all right, with two questions, one quite a broad one and one quite a narrow one, if I may. You know, I've sat on this committee for 6 years, without break, I know. The chair is saying wow very loudly in my ear. No, absolutely, I'm not expecting one, Councillor Gandy. But that statistic of the POWIS, if you like, the disproportion between only 20% of our patients, but causing 50% of our discharge delays is completely new. It sort of comes out of this like a bolt of lightning, really. And this isn't me having a go at the our friends the other side of the border, because we're all in this together. But I was just struck, Sarah, that you talked about the plan and the various different sort of schemes, but it felt like it was still very much in development or ongoing or in progress. I think one that jumped out was the IVOPAT scheme, expected to launch in September. Well, we're already at the end of October, so I'm surprised even to see that on a slide. Either it was expected but won't be, or has been. But we are at the end of October. This is about a winter plan. Is it going to be ready in time, I think, is what I'm asking.
Yeah, so just to be clear, these are Powis's plans. These are not Wye Valley plans, because we can't make plans for Powis. So these are Powis's plans, and this is what they're telling us. They wrote the slides and submitted them to us to say, this is what we're going to do to try and support that reducing demand and also speeding up discharges. So I absolutely hear you. We've been here a while. I've been around a while, and the story's the same every year. I think, and this is perhaps speaking from a personal level, it feels a little different now, in that we, I think rather than just the direct challenge to Powis all the time, discharge quicker, stop people coming in. It feels a little bit different this year in terms of, okay, let's hold your hand through it, not to be patronising, but we've kind of done this. I think that the management team over there seem much more receptive in terms of hearing how we've done it, because we're quite far ahead in all of this stuff. As I've said before, because we're working, the two organisations have been working for so long together, and we still have our bumps in the road, don't we? But actually, we do really well at this. So it just feels slightly different in that they are much more open to hearing how we do it, and therefore how they might be able to do it, but also going that step further and saying, do you know what, let's test this, and if you need some help from one of our geriatricians at Wye Valley, we'll be available by phone to support you. So it does feel slightly different. I mean, their plans are the plans. Are they going to be able to deliver all of that for this winter? I don't know. As Sarah says, it's out of our control. But I guess from a personal perspective, hearing these plans, knowing the meetings that we've got coming up in the next few months are regular, we're going to be looking at these plans, we're going to be understanding how they're going to commit to valuing Powis patients' time in the same way that we're valuing patients' time generally. It does feel like there's been a shift. I am quite an optimistic person though, but hopefully not overly optimistic. I'm hoping it will be a bit more successful this year.
Okay, thank you. That's encouraging. And I fully appreciate the situation you're in. But yeah, if the mood music is a little bit better this year, perhaps maybe. Now a specific point. Again, I appreciate it's on their plans, not yours, so to speak. And of course, Councillor Crockett has slightly trailed my coat on this one, and it's a topic that I'm not going to point at you because of what you've just said about only having been in post. But again, another thing over the last 6 years has been MIUs, and it has run through this committee like well, I can hardly say a golden thread, perhaps more like a rusty thread, really, of discontent. And we've had motions to council, letters to secretaries of state. So it has. So I know you said you were going to look at the history of it. Set aside a fair amount of time because there's been quite a lot of it. But I was really attracted by what it says about the Powis development. I just wondered if you could shed any more light on it, Sarah, and what they are thinking in terms of their MIUs. Any information that might ultimately influence or be shared with MIUs on our side of the border would be most welcome.
The straight answer is no. I know that they've managed to recruit a GP in Powis. That they haven't had before. So I think this is what more might we be able to do with a bit more medical support. So no, I don't know the details behind their plans, but I suspect it might be linked to what might be able to do, probably for our frail older population, with the skills that the GP is bringing. But yeah, I can't answer any more than that, I'm afraid.
Can I just jump in, Councillor Tillett? Is that
Yes,
all
of
right?
course you can.
I just wondered if Hillary's got anything to comment on from the local authority side of things about working with Powys and discharges, or even Councillor Gandy.
More sort of political.
Yeah.
So from a officer point of view, we have I have regular contact with Powys. We've offered them help in terms of, you know, for example, in terms of hosting a social worker in Wye Valley to help with assessments and discharge. We've worked with them to offer with our commissioning to offer care home placements along the border to help the flow out of the hospital. So we've had regular dialogue with them. Not all of our suggestions have been taken up by them, but we've always been very open to working with them.
Councillor Gandy, did you want? No, okay. It is definitely. Councillor Tillett, have you finished? Or?
No. I'll burble on a wee bit more. So, Sarah, changing the subject completely. I think you said your target for staff vaccinations was 15%. I do find that extraordinary. No. What was it?
So staff vaccination, we're currently at 23%,
23.
and the national NHSE team have asked every NHS trust to increase their performance by 5% from last year. Now, I'm not sure what Wye Valley's was last year, but we are certainly doing better now than we were this time last year for vaccinations.
Right, but it is still strike me, and as somebody who's had so many vaccinations in the last 2 or 3 months, I'm surprised this glass of water isn't going straight through me. It just does strike me as, it seems like an easy win, really, to be more secure about staffing levels, and it also seems to me almost counterintuitive that people who work in the front line of health services would not want to be vaccinated. I'm not going to ask you to sort of surmise on why that's happening, but it just, you know, it just seems to me an easy win to make sure that we are having as many members of staff reporting for duty, irrespective of whatever outbreaks, and Councillor Cole may be right about flu and so on. And if I can just add to that, since we're on the subject of vaccines, and again, it's very, very early for you, I appreciate this, but is there any expectation, perhaps within the NHS generally, about the impact of reducing the cohort of the public who are being given COVID vaccinations and restricting it to now the over 75s rather than the over 65s, as well as obviously other special qualifications? Is there any sign or is there any expectation that that may create another challenge to this winter programme?
So we do receive regularly surveillance data around COVID and flu from UCSA, so the UK Health Surveillance Agency, and the only thing that we've been asked for at the moment are our plans of how we'd manage a flu outbreak and how we'd manage COVID and respiratory viruses. So there's nothing coming down the line yet to say that we're expecting a big spike, whereas last year we certainly did for flu. We knew that we were going to get, all trusts were going to get hit hard with flu, but no, not at the moment.
And is it right at the moment we've got a bit of a outbreak of COVID again?
We did have a bit of a spike, but now back within manageable levels.
And is that staff as well as the general public?
So our infection prevention control procedures now, we don't encourage staff to test. So if they feel well enough to come into work, then they come into work. And so it's difficult because we don't routinely test.
Yeah, it's a really difficult infection to monitor and advise on. Thankfully, it's not as bad as it was when we had the initial situation. Have you finished, Councillor Tillett? Councillor Davis, I think you wanted to say
Thank you,
something.
Chair. Yeah, I just wanted to come back in with a question on the whole winter plan. And a key element to this is the re-enablement of patients to get them back home, because it's the best place for them to recover. So the enablement teams are a key part of that, but also to get them back home and out of the system. We need, I think, to possibly put them into residential care in a preamble before them going home, maybe, if they need that care that fits between critical care in hospital and then being able to support themselves back in their own home communities. Is there a plan to integrate more with private care, potentially?
Sarah, do you want to come in on this one? Because I'm not yet sure what we're doing.
Hilary might want to step in as a bit more of an expert than me.
Yeah,
But,
yeah.
Hilary, it sounds like more of a commissioning question, but certainly from a pathway perspective, we already have Hillside, which is the facility that we use for our discharge to assess bedded residential home patients. So exactly as you've just described, they are clinically optimised to leave hospital. We're not quite sure whether they're ready to go home yet, so are transferred over to Hillside to have some therapy and care. And reablement to enable them then to either go home from Hillside or actually they might well need permanent long-term care. So that's the process that's in place at the moment in the pathway. But I'm not sure that I can answer anything about commissioning private companies, but Hilary might.
We don't routinely commission private companies in that way. We do use bedded provision, as Sarah's outlined, where people need respite or some additional support before going home. But happy to talk to you further about those points you've raised, if that would be helpful outside of the committee.
Thank you, Hilary.
Yeah, thank you, Hilary. I was just wondering whether or not it might come to the point during the winter months that we require additional capacity in the hospital, and consequently it might then be financially viable to look at the options of empty care beds in the private sector to help move patients through the system. Just a suggestion.
Yeah, so we already, yes, Hilary, do you want to talk about spot?
No, do you want to go? You go first, Sarah.
So now I was just going to say we already have to commission spot beds, we call them. So when Hillside is full and when our other D2A capacity, which is at Ledbury in the care centre there, when they're full, we have to go out to the market to purchase additional beds so that we can keep that flow going. It's expensive for us as a system, and it's something we desperately need to reduce. And Hilary and I, when we talk about reviewing the D2A model, it's very much around this model needs to be value for money, and we need to reduce the amount of those spot beds that we're buying in the market. But yeah, it's already in place, has been in place for a number of years, but we're really aiming to reduce it where we can. But we need it right now to keep the flow going.
Thank you again, Sarah. I think we're going to come back to Councillor Tully in a second, but sorry, can I just, you talked about communication and trying to get the right people to the right place, so that they don't block up the emergency department, but how can you and we encourage residents to use the right service at the right time? And also, are there any campaigns between us, the local authority, and our public health teams that can support you in that venture?
So I think it's certainly the work that we're doing with primary care, absolutely, around if a patient needs a level of review, that actually they directly access the right service. So it is about phoning the single point of access. It is then about that patient getting directed into the most appropriate service to meet their needs. Sarah and myself have touched on the 111 service. So, patients need, in order to access, that kind of emergency healthcare, they need to go through 111. So actually hopefully that will begin to make a difference. So and other than that, it is the campaigns that run all of the time, don't they, about don't come into accident and emergency unless it's an accident or an emergency. The neighbourhood health work and the kind of some of the change management programmes which are being proposed within that, as we move into more of that space, then that should begin to have an impact.
And I think that's one of the problems without having the minor injury units, because people feel if they need support, they go to A&E or ED. And, you know, we all know that it should only be for emergencies and accidents, because then we could cope with it. But, you know, it's getting it out there that, you know, there are other places that you can seek advice. And especially, I don't like to add more work to the pharmacist, but, you know, go to the chemist and see your pharmacist, because that, I think, is a bit underused. Councillor Tully, did you want to come back?
Yeah, thank you. So a couple of things. One was you mentioned the Worcestershire percentage of calls working with 111 and avoiding ED. Please, can you share what went well and how you did it? Because it sounds like a really excellent thing for Herefordshire to learn from. I mean, I don't mean now. I just mean, you know, that obviously it was a very clear shift, and that's brilliant.
Yeah, and I have to say that Sarah's team and are working closely with the team who've set up single point of access over in Worcestershire. So there is very much shared learning and support there.
Brilliant.
So, yeah.
Amazing. Just thinking about the community hospitals, I've definitely got experience of those community hospitals being a place where there's a bit more waiting than people would want, waiting for that discharge. And I guess while that's being looked at, one of the things I was thinking was around, you mentioned in the slides about training within those community hospitals. I'd be interesting to know kind of what you see as success in, say, a year's time around how people have changed the way they're working or whatever in the community hospitals. But in the meantime, it seems that there's an opportunity if people are in those spaces for longer than they'd maybe like. Thinking about one of the aims of the trust generally over the year, I know that hospital food has been an issue that you've been working on. Well, if they're in there quite a long time, then they can get really well fed. So kind of how are those aims that you've got, those year-round aims that are not just winter, that are the whole year, how are they feeding into that winter plan? And perhaps, you know, will that be included in training for the people in the community hospitals and those kinds of things?
So in relation to my point around training, it's both. I think where we are now as a trust is we need to explore what potential have our community hospitals got over and above what we do with them now. Okay. But in order to do that, we kind of need to look at the pathways and the types of patients that are currently. So, for instance, again, going back to learning from Worcestershire, what we did is develop what we called an Out by 5 programme. So this was our fractured neck of femurs who would stay in hospital for anything up to 2 weeks because they needed ongoing support before they could go home. We introduced that those patients were going out to 2 of our community hospital wards where we trained up the staff. So acute teams went out, trained the staff up. And those fractured neck of femur patients went out on day 2 or day 3. So we achieved a 60% length of stay saving across that pathway. We then extended out to frailty and other conditions affecting general medicine. So then it was a 45% reduction length of stay across those patients. The question I've asked the clinical teams here in Herefordshire is, what can we do differently? How can we change the type of patient that we actually transfer out into community hospitals, where they're in a better environment to suit their needs, and where they will receive more rehab and more potential. That's what I mean about training community hospitals. What can we do differently, which would reduce the bed occupancy in the acute side of the trust in order to remove borders and make sure we can get our ambulances in.
I think just listening to all of this, the really positive thing that I've noted is that, you know, the diagnostic centre has now opened, and you know that's a huge benefit, because that would support MIUs, because if somebody goes there and they think they've broken or twisted or whatever, they could be sent there into, you know, not into the city, but, you know, to a purpose-built building that they could hopefully see them quite quickly, get the X-ray or MRI done, and then that could be reported straight back to the MIU, and then that person would hopefully get a better result to their injury. So I think that's a positive, definitely. Any other questions? Councillor Tillett.
Perhaps I should have tacked this onto my vaccination questions, but it is a more general question, although incredibly pertinent to the winter plan. Broadly speaking, what are staffing levels like? And beyond that, you know, how confident are you that you're going to have sufficient staff to cope through the winter, and what sort of contingency plans have you got for extra staff and absence and so on?
Okay, so our staffing position is good. So from a nurse point of view, we are more or less fully staffed. You get your normal turnover, your normal attrition. From a accident and emergent perspective specifically, before I came into post, the Trust had approved a business case to increase the numbers of A&E consultants. So the team have gone from 6 up to 10. And by the end of winter, all of those 10 will be in post. So yeah, you've got your senior decision making, extending the hours that those consultants will be on the floor, supporting the teams, and obviously giving the patients the best care. And also from our kind of ologies, we call them. So our, you know, respiratory, gastro, all of our key specialties. We've also been really successful in recruiting consultants and, you know, our medics into those specialties. So from that perspective, we're in a good place. The actual challenge is around when sickness comes. We've talked about flu, we've talked about COVID, and and this is the question around performance, safety versus the financial savings that we have got to make around reducing agency and bank spend. So we will carefully be monitoring, and again, it's that risk assessing 3 or 4 times a day to make sure staffing levels are safe. But there is an added complexity this year because of the real drive around money.
And just finally from me, I just wondered about the children's department. You know, A&E and ED has a separate area for children to attend. And, you know, we're looking at health care and wellbeing throughout the ages. So is there anything specific that you need to look at or change from the children and young people side of things? Or are those numbers more manageable, and treatment, etc., gets completed more readily, more rapidly?
Yeah, so the performance, the access targets around the children and young people coming through our A&E department are very good. That's not the challenge, it's adults.
I thought that, because we have quite a high number of paediatric consultants, I believe, considering you know, the workload that we have. So perhaps they could come and work in the adult world. I better not suggest that. Okay, any other questions or comments or concerns? Nothing else from any officers? Anything from, no? Okay, so again, thank you so much, Sarah. You know, it's been a great double act, and perhaps we'll get you, Sarah, us into the room next time, because you've played a big part in this. So what we need to look at now is so the purpose of this was to consider the winter plan for Wye Valley Trust, and so we have a recommendation that the covering report is, we look at it and perform questions and determine any other actions or recommendations that we may seek. So is there anything that committee members have burning in their thoughts, or should we just go to our scrutiny officer?
No, I've not had any recommendations.
You
Chair.
haven't, okay. So for me, I just wonder whether we should or could ask for a briefing from either Sarah or these slides, and somebody coming to present to all members on a virtual footing. Whether Councillor Gandy, you've got anything in the pipeline to get an all-member briefing on this winter plan?
We haven't.
No.
But we could have.
Do you think it would be valuable? I do think that all members should be aware of what Wye Valley have proposed and are having to go through. So can we?
Did you want to make that a recommendation, Chair?
Is it a recommendation, or is it just a briefing request from Wye Valley to Wye Valley for, yeah. So we'll go with that one. And yes, of course.
Just a comment on that. I think, yeah, it's always good to share information just around the confusion that I had about what were targets and what was a plan, and I think it would be helpful to have maybe a little bit less information, but really what the actual intention is over the next 6 months, as opposed to the plan that had to be written. What's actually planned. And the other suggestion I have, while I've got my mic on, is just, is it a recommendation to ask that we have an update in, say, April around some of these intentions, especially around around Powys, and the fact that it's 20% to 50%, and what are the changes, and it's just an update in April along those lines.
Yep, is that okay? Do you think we could have an update in April?
Yeah, we could add something else to the work programme for you, Chair.
Yeah.
Will we also
The other query I've had is several people have commented about, the ambulance services. So I think rather than making a recommendation here, we can add it to our work programme in the next agenda item. Yeah. So again, thank you very much, Sarah, and we look forward to having a trouble-free winter. I shouldn't say it, it's not going to happen. But you can only live in hope, can't you? And yeah, we'll do everything we can to support you. So can I have a proposer and seconder for this agenda item? Yep, there we are. Yep. Okay, thank you very much, Sarah. Thank you. Okay, so we can move on now to item 8 on the agenda, which is the work programme for 25-26. And I accept we've got a couple of variations of this, but we have
the right one.
yeah, we have the agenda supplement number 2, which is the up-to-date one. So what we need to look at is the draft work programme for this scrutiny committee, and this is until July 26. Oh my goodness, that'll be summer again. That'd be wonderful. So I think, Daniel, you're going to just have a quick word about that before we start.
Yeah, thank you, Chair. You can find the programme that we're going to vote on as Supplement 1 in the agenda papers. Quite a busy work programme ahead. You've got 5 committee meetings coming up. You'll be looking at the Herefordshire and Worcestershire Health and Care NHS Trust strategy in November, and I believe as well they'll be focusing on their move towards community-based services. I know that you've been talking about minor injuries units, and obviously Sarah talked earlier around the proposed Wye Valley Trust strategy around emergency healthcare. So you might want to bring all of these 3 topics together in November. Also in November, you have a briefing on community activities. This follows one of your earlier meetings. This was a committee recommendation that you received this briefing. We're hoping by January that the CQC inspection of Herefordshire councils would have come to fruition, and we will have the inspection report and the resultant action plan. And we're proposing a topic then around shaping neighbourhood health. This is following on from the trust strategy that will be presented to you in January. Then finally in March, we have the joint strategic needs assessment and health and wellbeing strategy, upon which the strategy which is based upon the JSNA, which is also going to be presented to you. And finally, you mentioned around the annual report, and the chair has suggested that we bring that as a briefing to the committee rather than as an agenda item. She feels that there is insufficient reason to bring it as an item, in terms of we don't really have a set of clear objectives as to why we might bring it. So let's have a briefing on it and see what it says first. Thank you, Chair.
Thank you. Any comments from any committee members? I think the good thing is we're flexible with this, and we the committee discuss it every month to see if there's something we should bring forward or push back or add on. So I think this is a fluid committee agenda. So I don't think anything is controversial at this point.
Chair, if I might.
Yeah.
One other thing I forgot to mention, piece of ongoing planning. Councillor Tully asked for a piece of work around hospital food. So I'm just in the process of arranging an all-member briefing following that request. So as soon as I've got any news, I'll share that with you.
Okay, and the other thing that Councillor Tully was enthused about was nutrition in the hospital, and and also the patient participation group, which we feel is perhaps lost now. Some areas have closed their engagement, so we'll bring that through the meeting with Health Watch.
Yes, I'm going to say it's on the 24th of November.
Yeah. So it's covering those 2 items that Councillor Tully was keen to explore. And again, if anybody has any further thoughts on anything that's really important that we need to look at sooner rather than later, we can adjust things. So the purpose is to consider the work programme, and no other comments or anything. So the recommendation is that the committee agree the draft work programme contained in the work programme report attached as Appendix 1, which is subject to monthly review, and the committee note the forward plan attached as item agenda 2 supplement. So please, can I have a proposer and a seconder? Okay, perfect, thank you. Anybody against? All for? Yeah, thank you. Okay. That concludes today's business, I do believe. So
I'll try and get the briefing sorted out before Christmas, because otherwise it'll be too late. Really.
Yes.
It'll be halfway through the winter.
yeah. Absolutely, thank you.
best, but obviously it will rely on Sarah being available.
Yeah, thank you, Councillor Gandy. So item 9 is the date of the next meeting, and that's not too far away. That's 24th of November. So I would like to just close this meeting. Thank